Okay, we are live. Welcome to Boston Basic Income. Today we are talking about, I'm Alex Howlett. Today we are talking about healthcare. So healthcare and basic income. So some of us read an article called What Healthcare Needs, Real Consumers and Dynamic Competition. So is that really what healthcare needs? And it's an interesting question because when we talk about consumers, that's in the realm of basic income. So we can ask, to what extent would having a basic income, instituting a basic income, have an influence on healthcare? And kind of what would those effects be? So I want to go around the room, starting with that question. The article is by David Goldhill. So I want to start with that question. What effects do you think basic income would have on healthcare?
Well, assuming we're not changing the healthcare system,
or what would it change about healthcare, or anything? You could assume, maybe, if the healthcare system were set up in this way, in a certain way that you want, does that make basic income have a better effect?
Right.
That kind of thing. Yeah.
So I think basic income. A high basic income can't easily eliminate unnecessary jobs without healthcare being not tied to jobs. Mm-hmm. So that's kind of why I was not sure how to answer the question, because it depends on whether healthcare remained tied to jobs or not would make a big difference.
Yeah.
I think any cash transfer, like any basic income, would reduce probably like many chronic diseases, or it would improve health. So it would take a little bit of the burden off the healthcare system. And the amount of the basic income would have an influence on that.
Yeah.
Basic income. I didn't see an automatic, natural connection in this, but there were some interesting things to talk about. But I see it on the other side. If it has an effect, then it has more of an effect for people who don't have health care but have health problems and are going to go broke if they don't have built up some kind of income, some kind of savings, which basic income would allow them to do. So it's just like any other emergency, they now have this extra money to put aside for possible health care needs. But the system itself, I like a lot of the points, but we'll talk later about the things about it.
The points in the article?
Yeah.
Yeah.
That make it complicated.
Okay. Steve?
Well, I think that UBI assumes that people can decide for themselves how to spend their money and what they need. So I'm wondering if shopping for health insurance or health care is not any better or worse than any other kind of shopping, and that people can manage it the way they shop for anything else important.
Yeah, Richard.
Well, in the 70s, Canada's Mincome experiment had a decline in health costs of 8.5%, and they had socialized medicine. In the U.S., we don't have socialized medicine, and so I'd imagine the health costs would decline 20% or something like that, at least, because of the better outcomes of, people like children wouldn't have babies malnourished, and babies wouldn't be born as underweight, and that can be really expensive, putting them in incubators and things like that.
Right.
Let's see, and then there's equipment, they talk about how best practices are in an article, and recently it was shown that there's a robot that can clean toilets and things, spraying them down and things like that.
Yeah.
And there's also, for actual hospital rooms, there's a robot that goes about using UV rays.
Yeah. Mm-hmm.
And so even microorganisms like bed bugs and things like that, if they were sprayed enough times, they would die by UV light destroying their DNA.
Mm-hmm.
Cool.
Yeah, right.
I like that everybody brought up different points.
Yeah.
And Mitchell says that basic income may lead to healthier lifestyle for some in areas including food and fitness, knowing that you have a steady income for those recurring expenses. Yeah, I think that's right. And maybe, people won't be so kind of strapped for resources that they can actually, work on their mental health, maybe prevent themselves from falling into addiction, that kind of stuff. They can take the time to take care of themselves on their own, which is a part of healthcare, but it's not usually what we think about when we talk about healthcare. When we think about healthcare, we think of doctors and hospitals, but basic income certainly gives people access to the resources they need to take care of their own health more than they're able to now. So to frame our discussion, I've written 3 words on the board, and you guys can tell me whether this makes sense. So I've divided healthcare into 3 categories: preventive, routine, and catastrophic. So preventive healthcare is the stuff.
Flu vaccines and things.
Flu vaccines, yeah, the stuff that you probably should be doing regularly, but it's not urgent and you don't necessarily feel the effects of it right away. But it's like regular upkeep, that kind of thing. And then routine is anytime you get sick, you need to go and get it taken care of. Maybe you have a chronic condition that needs regular things. It's something that
mammograms and things.
Might be preventive.
Mammograms would probably be more preventive. Routine is more about stuff that you feel, like you feel the effect, like, oh, I know I need to go do this because I'll feel better, once I've done it. It's something that you have more kind of a connection to. And then catastrophic is
heart attacks and things.
Yeah, so it's stuff that's really costly that happens, and it takes a lot of resources to deal with. It can't necessarily be anticipated. It's not something that's likely to happen at any given time in particular. It might be a once-in-a-lifetime thing, or, these kinds of things might even be the kinds of things that don't happen to everyone, but they do happen to some people, and we need to be able to handle it when it does happen. So it's my argument is that the routine stuff is the stuff that is amenable to normal market incentives. So you get sick, you have an incentive to feel better. You want to go and get it taken care of, that kind of thing. The preventive stuff, some people, if they're diligent, they might do it on their own. But a lot of times, people will put this kind of stuff off. It's not urgent. It may not get done unless you provide some kind of additional incentive to do it. If you pay people to get their preventive care, to take care of their preventive care stuff, or you fine them for not doing it, then that kind of maybe pushes it more into the routine category, because now it's something that people feel directly, and that can help it be maybe more market-based. For catastrophic stuff, you can't plan for it. Even if you wanted to plan for it, you couldn't. If you're imagining something that doesn't even happen to 3 out of 4 people, it would be a waste of resources if all 4 of those people planned for this catastrophic thing, right? Because now you're tying up resources that are more than what is necessary to handle this. So this is kind of where insurance comes in. And insurance moves the catastrophic into the preventive category. Because, now insurance is this thing that you have to buy, but maybe you won't. You don't have a strong incentive to do it still. Or it's not like an urgent incentive to do it. So maybe there are people who go uninsured, that kind of thing. So now you've got to do the next step of kind of like moving it into the routine, like punishing people for not having insurance.
Individual mandate.
Right, punishing them for not having insurance, or maybe paying them to get insurance, or that kind of thing. So what do you guys think about this kind of breakdown here?
Reasonable. I'm trying to map it onto healthcare.
Yeah.
And I feel like there are obviously some complications with actual healthcare. So for example, with routine, some people have chronic conditions, but those are actually really expensive, even though it's routine.
Sure.
And you might not know ahead of time if you're going to develop one. So there's a little bit of blurring of the categories for me. But
I would say, developing the chronic condition probably falls under catastrophic, but then once you have it, it falls under the routine.
Yeah, I guess another thing that isn't captured yet by this is just like the magnitude of the expense. And like part of what seems to be happening with quote unquote health insurance that's different from something like car insurance is that it's like part of it is just like your employer or whatever is just paying for the expense of those things, which I guess kind of feeds into like your incentive to do the preventative stuff. But it's sort of a funny thing where like part of the issue is just that it's extremely expensive beyond most people's incomes. And so like, but instead of getting the income directly, they kind of like get it supplemented by the company. It's sort of like a weird thing I haven't quite figured out.
But isn't the
So
expense
this framework is more. So a lot of these problems also have to do with kind of like the way our existing healthcare system is set up, and a lot of the inefficiencies have to do with that. So this is kind of like a more general thing that I'm imagining. If we're imagining an ideal healthcare system and what it would look like, you'd still have kind of these three categories of things. And in terms of how expensive things are, well, we have, as in any, part of the economy, we have a certain amount of resources that are available to us, and we want to allocate them efficiently, right? So it doesn't really make sense to kind of like say, oh, but it's really expensive or something like that. It's just a matter of we have these resources and we want to allocate them. Yeah.
not really following how this lines up either with. I mean, insurance is expensive partly because it's capturing catastrophic and chronic things and averaging them out so that everybody has to pay, even though they're not going to suffer a catastrophic event.
So that's part of it. I don't think that's most of it. I don't think that's most of why health insurance is expensive here. There are countries that have health insurance that's 1/10 the price, that kind of thing, and they work fine.
But the consumer part that you're saying is the routine part, where there could be competition, let's say, competition for the market. That and the article brings that out pretty well. That's limited due to the lack of transparency that we now have in hospitals and in all medical stuff, really.
Right. So there's certain inefficiencies that are going on in our healthcare system that are not captured by this framework. I think that's kind of what you're saying, right?
I'm saying specific things that are not captured, right? Yeah.
Right. And I think that's right. I think there's, with the lack of transparency, and then there's other things like quotas on how many people get to be doctors, and
how many nurses per patient, and how hospitals operate, how they best meet their bottom lines, all that.
And then there's privacy issues. Yeah. This doesn't capture privacy. Privacy is a huge thing, and it inhibits, collaboration in the medical field. It inhibits competition because you can't necessarily see how was this person's case handled over at this doctor. You can't just look at all of the medical records and say, oh, this guy's surgeries aren't as good or something like that, because that's privacy.
Right, and also the fear of lawsuits. I mean, there was an article in the New Yorker about at some point they decided that to lessen lawsuits, people would be let in to see life-saving measures. Usually they weren't, because the doctors would be afraid that the people wouldn't understand what they were doing, and then they'd be subject to lawsuits if the person died. But actually, it turned out if people did see what was being done, they'd see the amount of effort, they'd see the life-saving efforts that went into it, and the lawsuits dropped. The number of lawsuits dropped. But the fear of lawsuits was a big issue of not letting people understand what's happening.
Yeah. And in some countries, suing a doctor is illegal. You can't do it.
Oh, really?
Like Australia.
And in certain states in the U.S., they limit the amount who can win in a suit to $250,000 or something like that, when it used to be had no limit. You could get millions of dollars for it.
Right. Yeah. And making mistakes. Yeah, you can't learn from other mistakes because the mistakes are covered up.
Right.
Yeah. I do have a problem with this. I can't really help with this. With car insurance, you can actually gamble. I think all insurance is a kind of gambling. With car insurance, you can gamble that you're never going to cause an accident and have to pay somebody $100,000 for your whole life. And I guess a lot of people win that gamble. When it comes to a big medical problem, I'd say that just about everybody, and certainly after age 60, is going to have a multi-$100,000 medical problem. People who are younger than 50 or 60, they really can gamble. And some of them will have a skydiving or motorcycle accident, and they'll lose.
Right.
But it's actually possible to win the medical insurance thing for 40 or 50 years.
Yeah.
But after that, it's really there's no insurance in the sense of gambling. Every old person is going to need hundreds of thousands of dollars.
Yeah, I think that's right. So we could say that once you're old, old age is a chronic condition, and you have a lot more routine health.
Yeah, it's not even.
And I guess there's a higher chance of the catastrophic things happening.
Or like it starts to be that you might think of the catastrophic as something you could plan for. That's maybe more like your routine thing. Because
so maybe what for a young person would be a catastrophic event would be more anticipated.
But I think it's hard because I take your point, but you still might not know if it's going to be a few 100,000 or millions, or like there's still maybe like a lot of uncertainty in the amount of the cost or the number of the events. And
there's also, at least in our current system, nobody knows what the true cost of anything is, right? There's prices for everything, but what does that reflect?
In the medical system?
Yeah, in the medical system.
I know.
Yeah, like a little packet of Advil or whatever is like $70 or something like that, but it should only cost like $1.
Right, I know.
Right.
I know.
Yeah.
Eric used to get into that in the hospitals, but it's like the military, really.
So
jacked up prices.
Yeah. So that's a tricky thing. So it's not even that. So you can't even have kind of price competition if nobody knows what the prices are. So that's an issue too.
Yeah. Right.
So like if I'm imagining an ideal world in which routine care was priced correctly, what does that even look like?
Right.
Right.
Yeah.
And how do you provide the incentives for the prices to be? Right. And I guess he talks about this a little bit, like if something costs more, someone complains about it, and post on the Yelp for medical care or something like that.
Yeah.
But
I mean, there are some things that are known about hospitals' outcomes. I mean, they do ratings all the time so that we know Mass General has better outcomes for certain kinds of diseases than some podunk place. But other than that,
and what's really important for a market to be efficient isn't just what are the outcomes; it's what are the outcomes relative to the prices.
Yeah.
Right.
Right.
So you've got one side of that, but you don't have the other side. Right.
Yeah.
And if you have your insurance, you're not paying anything more by going to Mass General or something like that. But we would expect in a market, the people who wanted the better care would or had a more desperate need would be willing to pay more. Right. Assuming that everybody actually has access to money, which they would under a basic income. So this is the part that basic income helps with, is that if everybody has money to spend, then you can decide, what level of care you want to pay for, that kind of thing.
And where you can move to.
For the routine stuff. Yeah, go ahead.
I guess we'll get into this with the article, but so I know vaguely of examples with like socialized medicine, essentially, like the government provides it. Are there examples, and then we have our example, which is like, it has many problems. Are there examples of kind of like places that do it more like what you're talking about? Like people have enough money and then they kind of treat medical care like a market?
It's hard to do. So Anna Chris is hopefully going to be here in a little bit, but she's from Mexico, and I think I remember hearing that in Mexico they charge like a nominal amount to prevent people from just getting unlimited free care, like that kind of thing.
But that's different from what I'm talking about.
What are you talking about?
I'm talking about you seem to be implying that like.
So we've never had an economy with a full-scale basic income.
Yeah,
so we've never had a situation
there are
where
lots of other things that we have the market handle, and I'm just wondering if there's any examples.
I mean, so you're asking, so it's tricky to let the market handle medical care or health care when people don't have any money. So I don't think there are examples. I mean, obviously at the high end in the United States, that's true. Right. But I don't think there are examples of countries where that's just the norm, except perhaps maybe in, like primitive cultures or something like that.
But then there aren't like so many services. So
yeah, like you wouldn't be able to get the, Cadillac, whatever anyway. Yeah.
Yeah.
Yeah. But yeah, I mean, so I want to provide another analogy here and apply these categories to another kind of thing. So let's imagine that let's talk about say you have an appliance that is malfunctioning and you get it fixed. That's routine. And let's say, it's kind of...
It's actually not so routine these days. They anticipate it's going to break down, and then they say, you need to buy another one because we don't have that part anymore, or something.
Okay, so maybe the routine is not actually getting the appliance repaired, but it could be getting the appliance replaced. But, for this model, it's the same either way. It doesn't really matter. And then the preventive would be, oiling the gears regularly,
changing the filters,
changing the filters, that kind of stuff, so that your appliance stays in good working condition, and then like checking it to make sure that nothing's about to break or something like that. So that's preventive, and then catastrophic would be your appliance causes an electrical fire and burns down your house, right? So you buy insurance for the last thing. You buy fire insurance. And it's important that you do because fires spread. If your house burns down, that increases the chances that all your neighbors' houses are going to burn down, right? So it's not... so we talked about kind of like rolling the dice and, maybe you can get away with it. You don't want people to be rolling the dice for this. Or you at least want... Maybe fire insurance is not the best example, but having a fire department. And what happens if your fire department only puts out fires for the people who paid? Right.
But actually, through private fire departments, they actually put out fires for other people around the houses that the people pay for their services for.
Yeah. Okay, but generally speaking. It's kind of there's a responsibility to not just let the fire go and not gamble in that way. And I think some of that applies to healthcare as well. You don't want people spreading diseases. You don't want people not getting vaccinated, that kind of thing. So we talked about the possibility of kind of getting away with rolling the dice. We don't want to let anyone get away with rolling the dice because that makes everyone else less safe. I think that's true in the fire situation, and it's also true in the healthcare situation. Do you want to say something about that?
I'm not sure. I don't know. I guess I'm just trying to figure out what you have in mind that would map onto this, and if you think it's better than, say, for example, Canada's system.
What I would have in mind for healthcare? Yeah, so I guess we can talk about that. So we can imagine a world with a basic income, and we know, as with anything, the resources for healthcare, there's only a certain amount of them. Maybe there are certain things that we have the resources to do for everyone, but there are some things that we really don't. So I mean, it's not death panels per se, but it's market-based death panels, right? You have to decide there has to be some mechanism for deciding who gets the fancy treatment and who doesn't, because the resources are limited. Normally, in markets, we use prices as that mechanism to decide who gets what. You have to have some mechanism for that in healthcare. And we do have those mechanisms. They're just really obscure and inefficient because no one wants to admit that some people are kind of getting treatment and others aren't for certain things. So what I imagine is that there would be some kind of pricing mechanism for routine care.
That everybody can see?
That everybody can see and that, providers can compete on as well.
But would individuals pay out of pocket for all of that, or?
Yeah.
And do you think that would be better than the way Canada does it?
I think for routine stuff, so you can ask, is it better that Canada provides the healthcare for free, or would it be better to provide people the money directly and then they can use the money to buy the healthcare?
No, I know.
So
I know.
yeah,
That's what I'm asking.
I think it would be better. Yeah, I don't think this is a situation where people can't be trusted to do the things they need to do to take care of themselves for that category. For the preventive and the catastrophic, I think that is the case. People can't be trusted to do the thing that's good for themselves and society. Yeah. So for me, it would be a little bit about trying to set things up in such a way that the preventive feels routine to the patient, and then the catastrophic feels preventive, which then feels routine, that kind of thing. And you'd still have to have insurance for the catastrophic stuff, but insurance is only necessary for that.
And how would you keep,
is your house burning down?
And how would you keep the prices from being super inefficient?
Right. So that's a really important question.
What was it?
How do you keep the prices from being inefficient? So
Inefficient.
Now we have insurance, and so we talked about, the insurance has to pay whatever it costs the hospital to do certain things,
Right.
And so the costs are insane the way that he was talking about.
Oh, the insurance
Right.
inefficient in the sense that it's.
So there's no incentive for hospitals to keep their prices low, because if they know the insurance is going to pay for it, if they can get the insurance to pay for it.
Actually,
Yeah.
Andrew Yang has a plan for that, where if they don't agree to keep the prices at a certain point, then he'll take away their, say for a medication or something like that, they'll take away their property rights for that medication and have the government produce that thing, that medical device or that whatever by itself, and until or he'll hire another company to pay it, to create that thing. And so that would keep an incentive, provide an incentive not to keep the prices at 700% above whatever it is.
Right.
Yeah. It's tricky to get the incentives right, and it's tricky to know what to do to get the incentives right.
Yeah.
Sometimes there might be obvious cases where we're okay, we know we need to do this, add this specific competition here to bring down these prices and that kind of thing. But it's not something that can kind of be planned.
Because I can already think of two problems with that.
Yeah, go ahead.
One, how do you know you're not setting the price too low such that you're not incentivizing whatever the whole reason was for having intellectual property, like the research into the drug?
Right.
And then two, how do you know you're not setting it too high? How do you know where to put that bar?
Right.
How do you know how much profit they need to be making? I mean, not that it's not better than the status quo, it might be, but it's still hard to know.
Yeah, Anna Chris.
So
I want to introduce you. Anna Chris is a doctor, so she's got some
so we've got our
experience with
expert here.
And I'm also the roommate.
Yeah.
I missed a big chunk and portion of it, but I was discussing foreign policy with the ambassador.
Oh, okay.
So it was interesting. So I missed a lot, but I know that we will touch base later on this. But what I do have to say is, it depends on where are you looking. How are you framing healthcare? Is it being framed as system-based, government-based, or people-centered? Who are you centering healthcare? Who do you want to benefit? Do you want to benefit a system and have enough money to be able to sustain delivery to different types of services in a low cost? Do you want to sustain a government-led health system? Do you want to sustain an international-led health system? Do you are you focused more on delivery or more on profit? Are you focused more on prevention or more on treating catastrophes? So it depends on what you're focusing on, the discussion. I'm not good with economics. I should know economics, and it's something that they should teach us in medical school. But what I can say is, at least and I'm from Mexico, so in our health system, centralizing the health system into one entity, and then all of the money comes in from the public and private sector, and then it's sent to the centralized system, and then the government says, okay, there's an outbreak in opioid crisis, so let's aim X amount of money, let's say 20% towards reducing opioid crisis through blah, 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 whatever you want. But at the end of the day, there are other things that has been affected. And if you centralize this, you give X amount of money in an equal way to all of the states in the United States, let's say. If you decentralize the health system, you are asking the governments to be able to say, hey, we have this issue here, and the government will say, okay, I'm going to give you, out of this budget for opioid crisis, I'm going to give you 40% because you're from X state that has a very high rate of opioid crisis, and I'm going to give you less. But that decentralizes, and that you are not really knowledgeable on how much money is spent and how are they actually investing it. If it's patient-centered healthcare, it's different, and you're more focused as a government to provide and to make sure that all of your community needs are being met. So that's what I wanted to ask in terms of, okay, we're talking about a government health system. We're talking about a system. We're talking about a people-centered, or we're talking about private company-centered, or we're talking about like privatizing or deprivatizing all of the sectors. And that has a huge economic impact and returns in your country, because you could bring your prices up or you could bring it down. In the case of Massachusetts is actually an example of healthcare. So and I heard your trouble because there are a lot of gaps. There's still a lot of gaps, but this is kind of like the best healthcare system in America, Massachusetts, because it's extremely comprehensive. I just read the insurance rate. It is 3.3% of the population is uninsured. And within those uninsured, 8% are American citizen, 25% are non-U.S. born citizens but have been naturalized or have some sort of document, and then almost 50% are immigrants that are not being taken care of.
Yeah.
And then you see, like, okay, but Massachusetts is amazing. It has 3.3% on coverage rate. But it's one of the most expensive healthcares in the United States as well. So you see that and you're like, okay, why is that? So they're obligating through policies, they're obligating Massachusetts that you have to have medical insurance. If you don't have medical insurance, you will be fined.
Right.
And then the current rhetoric, one of it did not pass, but one of the reasons why they wanted to take the Obamacare is they turned it into, and I just read this for class, they used this rhetoric that they are making you,
Rhetoric.
Hey, mijo.
Want to make sure everyone knows what you mean.
Right. La retórica. They're using this rhetoric, damn it, and trying to explain that they are making you purchase something that you do not need in the case that you need it, and what this current administration is trying to seduce the words and move the words into is by not being obligated to have health insurance, by choosing whatever you want to choose, you are choosing freedom, and you are being free out of having to pay monthly secure plan, monthly routine, monthly catastrophic, monthly preventive.
Yeah.
But the reality is that a lot of people are impoverished by all of these three, that if you're not induced or obligated in a way to prevent a catastrophic event in your life economically, this has really helped some people and affected others, especially people that are below the poverty rate line but are not like in the middle gap between poverty and like kind of doing good in life. So that is a question to ask. What are the what's the political discourse on this right now? They're trying to move healthcare for all. They're trying to move international healthcare. In 1974, they said health should be free for all. By the year 2000, the international laws, the Declaration of Human Rights says that. So what are we moving towards? Are we moving towards profit? Are we moving towards the protection of human rights and health?
So I think that's a great question, and it touches on some of the stuff that we talk about in here a lot, which is that ultimately what we should care about is people, right? We want people to be as healthy and prosperous as possible. So whenever we talk about profit, it's important that the profit or the making of profit is aligned with making people better off. So we'd want to design our systems so that when a business is doing something that's profitable, it's profiting off something that's helping people.
Competitive advantage.
Right. So I like to talk about, with basic income, if you give everybody money, now the people, the consumers, are the ones with the money. So in order to be profitable as a business, you have to do something that makes the consumers better off. So kind of like aligning the incentives in that way. And I think the same thing probably applies to some aspects of healthcare. I like that you brought up, thinking about the individual and then thinking about like the health of the system or of the community, that kind of thing. Because when you talk about, addressing an epidemic, it's not about like one by one assessing each individual. You've got like a situation on your hands that needs to be taken care of. And this is the kind of thing that, people, operating in the market are not going to take care of for themselves, just by, oh, I feel a little sick, I'm going to go to the doctor. No, there's like something that needs to be addressed at a broader level. And this kind of thing is true for the greater economy as well. So if I have money, I'm going to go buy food and other goods and services that I want and need and stuff like that. But then there's infrastructure that, I'm not going to pay for 1 foot of a road to be built or something like that. Unless, and this is kind of, the government has to kind of take care of these other things. So it's a question that we have that we come up with a lot in this conversation, or that comes up a lot, which is what resources and what goods and services are most efficiently provided by the market and everyone kind of acting in their own interest, and which ones are most efficiently allocated directly by the government.
Yeah, and a little bit off that, but still connected, is bringing up the opioid crisis is interesting because profit versus human suffering. And I mean, the profit of what the Sacklers and those people, is immense. But OxyContin was brought up to relieve suffering. It was created really for a different reason, supposedly. It turned into this other thing. It became a profit-making thing that was based on people suffering.
So it was always a profit-making thing.
Right.
And, I don't want to get too much into the kind of the dynamics of that.
I feel like maybe...
Yeah, I was just going to say, even from the beginning, like, they knew it had addictive qualities and they hid that because they wanted to make money, right?
Yeah, that's what they say,
yeah.
But, I wanted to just focus on that a little bit because there's also the piecemeal part of it.
Yeah.
Treating people individually, that and Chris talked about,
right.
how inefficient that is. And then there's the piece of states asking for the government for money or needing more money, like Ohio is one of them,
Sure.
Needing more money for the addictions that are there and the deaths that are there.
Yeah.
And so if states were just left to their own devices, I think it would be less efficient. I think they need that government intervention in order to get the money allotted to them.
So federal government intervention?
Yeah.
Yeah.
You could argue that, well, the states should take care of themselves, and people do argue that. But when there's a crisis, like a catastrophe like that, there isn't really a way they can do that.
Yeah.
And that's true in the medical world.
So, it's true everywhere, right? Yeah. There are always some things that are most efficiently figured out at the level of the individual, or at the level of the family, or at the level of the community, or the city, or the state, or the federal government, or the whole world, maybe, right? We live in a global economy, global society, right? So there's different things that are more efficient to be accomplished at different places. You can't just blanket say states are more efficient. You can't just blanket say private companies are more efficient than the government or something like that. It depends. It depends on the characteristic of the problem that's being addressed.
The event, yeah.
And that's why Alex is trying to break it down into these different ways that the incentives are going to work for the individuals, which kind of relates to what's most efficiently handled by the individuals or not.
Right. So basic income is all about the individual.
Right.
It's not going to handle things that need to be handled directly by the state.
Yeah.
It's going to be handle things that handle resources that are most efficiently allocated by the market.
Right.
Some of healthcare falls into that, or could fall into that, maybe with some management by the state. Some of it might not. Yeah.
And that's kind of where our debate was, like, Anna Chris, when you came in, it's like, in what cases does it make sense to give people, for example, the money, and then they choose their healthcare versus you give them the healthcare? And that's not, for me, such a simple question, because some of the pros and cons we're talking about is like, if you give people, like, it can become very wasteful of resources, which ultimately means bad for people. We can't give people as much health care for wasting resources if you just try to give them the health care directly and there's nothing pressuring that to be efficient. But on the other hand, we were talking about, would people acting individually, would that be as efficient in other kinds of ways, like you were talking about with epidemics or things like that? So that was some of those, or which things, it's not like everything, but like which things in healthcare should you do one way or the other?
Right.
Was kind of the question he was raising.
Right.
Yeah.
And we were pointing out that for anything catastrophic, it makes sense to have insurance because that's something that you can't plan for. And it's something that you wouldn't want to force people to set aside resources for individually because it may never happen to them. Yeah.
So that's where I differ. I don't
Differ or defer?
Differ.
That's really important difference.
What's the difference?
Defer is to say, I'm going to go with your opinion. I'm going to defer to you.
Very different.
Differ means I differ from you. So I actually wanted to know. I wasn't trying to
concur.
make fun of your...
Do not concur.
So in that case, I
But
do
do you
not.
conquer?
I always concur.
Yeah.
So we shouldn't even be having a discussion whether which health insurance am I going to buy. How privileged I am to be able to afford a catastrophic or a routine or a preventive. Like that. So,
yeah, but we're talking about
So
an
I
ideal
should
system.
explain,
Yeah.
the way I wrote these words, they might not mean the things that you're used to. So
Yeah.
I'll quickly go over this,
Okay.
what I mean by these things. So when we think about people's health care needs, some things are things that just come up, like you get sick, you go to the doctor, get it taken care of, or it's something you're expecting, maybe you have, some kind of chronic condition that needs to be taken care of, and that's something that feels urgent to you, like you need to get that done, and if left to your own devices, you're gonna go get it done, if you can afford it. And then for preventive, the way I'm defining that is that these are things where it's not an urgent thing. It's something that's necessary kind of eventually or maybe on a regular basis, but you don't feel, as the patient, you don't necessarily feel like you need to do it. You don't have a strong incentive, so you might put it off. You might not go in and get it taken care of, that kind of thing. And then catastrophic is just anything that
Life-threatening things like heart attacks and strokes.
no, well, it's anything that can't really be planned for efficiently. So maybe it's something that is unlikely to come up, very unlikely to come up, so you're not going to calculate that into your planning, or it's something that takes so many resources you wouldn't even be able to set aside resources for it, you set aside money for it efficiently or something like that. If it's something that only happens to 1 in 5 people, then you don't want all 5 of those people, setting aside the money for, a heart attack or something like that. So those are kind of like the categories
So
that
like
I
if
broke
it were
down.
cars, then preventative we talked about
Right.
changing your oil. Routine is you have to get it checked and maintained sometimes. Catastrophic is you might get in a horrible car accident where you kill someone or maybe
Right.
at least injure someone or something.
So
but
I know-
hopefully you won't, right?
So
It's
I know
hard to,
these words
plan for
are
that.
often used to describe different types of insurance, but that's not
Oh, yeah.
how I'm
That's
using
not how
them
it's used.
here. I would say that, if people have money, then the routine stuff can kind of be handled by the market. If you have a basic income, then, we can allocate routine care by just saying, okay, this is how much it costs and pay for it. Hypothetically, it could be efficient in that way. For preventive, it's not going to work that way because maybe people aren't paying for the things that they need to pay for, the preventive care that they need to pay for. So you need to provide some sort of incentive to get people to do it. And then for catastrophic, that's the category where no matter what, you're going to need some kind of insurance for that. Because otherwise it's just a really inefficient use of resources. You want to pool everyone's resources and kind of direct it where it needs to go.
Yeah.
And that's what insurance does.
Because insurance, if we
Yeah.
all have a 1 in, how many are there? 1, 2, 3, 4, 5, 6. If we all have a 1 in 6 chance of something, what we really want to do is put aside the cost divided by 6 each. And that's
Right.
what insurance allows you to do.
Exactly.
Instead of each of us having to put aside the entire amount on our own. So it's much more efficient for those kinds of things. Yeah.
Yeah. So I just wanted to kind of give you that framework.
And insurance could be private insurance, or it could be that you're essentially paying for it because the government's providing it to you instead of providing you the money directly.
Right. The government can
Yeah.
be setting aside a certain number of resources for people having heart attacks and, making some actuarial calculations, anticipating, how many of those resources are going to be needed. needed, that counts as insurance too. It's just it's not insurance that you buy necessarily.
And you're totally right, Anna Chris, that this is not the world we live in like right now. We're kind of talking about like the ideal system where there would be maybe a basic income and there would be choices between like giving everybody a certain amount of money or the care or something like that.
Part of the problem is that if we're living in a society where some people just don't have any money, you can't say, well, this is $5. You can't let the market do it.
Because they don't have any money.
But if you live in a world where everyone has a certain amount of money, then you can. And it's not like the people who really need it will pay for it and that kind of thing. Steve?
I still think that every elderly person will need hundreds of thousands of dollars.
Right.
Yeah.
So it's not really a gamble. There's hardly any old person who wins.
Right.
Yeah. Most of them have died throughout history.
But nobody's really so lucky as to have perfect health, and then at age 72, they drop dead, on their wedding night. So at the moment, every old person needs hundreds of thousands of dollars. Basically, the system is just going to get too expensive, period. So there has to be some way to make it less expensive.
Yes.
And I'm going to, me and the article are going to say that we'll do it the usual way with consumers and shopping and price comparisons, and good old, competition and price pressure to lower the price of even catastrophic health problems.
And how do you do that with catastrophic health problems?
Well, one way is from the bottom is you have UBI. So you need to save up hundreds of thousands of dollars.
Yeah.
As a young person, it would be best if you started doing that when you were young. I'm going to make it simple and say that rather than the young paying for the medical problems of the old, the young will pay for the medical problems of themselves. So a young person should do whatever he's capable of doing, preventative and insurance and routine, but mostly just trying to save a lot of money throughout his whole life. And I guess it's called a medical savings account, so I'll run with that.
Savings account.
Health savings account. I'll run with that then. Now, with a UBI, pretty much everybody can afford to save something for their whole life. So that from the bottom, that's one way to do it.
Yes.
But the more interesting way is that some elderly people will be rich, but some will be poor. And if you can create a medical provider market so that there is market competition, there are hospitals for the poor and hospitals for the rich, then there will be just plain old market competition and the prices will come down.
So I think you're right that there are ways to especially with the stuff in the article like more transparency and that kind of stuff, to add more competition into the system. Incentivizing more efficient use of resources is really what ultimately makes it cheaper. Is that you're using the resources more efficiently, or coming up with new technologies and that kind of stuff. I'm not sure. So when you say whenever people talk about saving, I imagine why are people saving, and like what's the ultimate. What's the need there? What's the effect that it needs to have? And the effect that it needs to have is that you need to have money later.
Well, hold on.
Right.
Yeah. I kind of have like something to say to support this plan, but then also some concerns or questions that I have for you, and I think it might help with your question.
Yeah.
So on the one hand, like if I'm going to have to pay for my healthcare down the road, it does incentivize more prevention. So like if you're thinking in terms of incentives, that's one thing that it does. It's like I'm bearing the cost later, and I have a lot of agency potentially to influence how high my costs are going to be later. The flip side or the questions I have are like, even if I'm definitely going to need some amount of money, like I said before, it could range from a few $100,000 to millions, and so I still feel like I'm not sure how I plan. That's kind of one problem. And I guess the other question is like, how do we want to handle people having a fair amount of like delayed gratification or just generally not being so good at saving? And do we want to just say like, fine, they just die and like that's okay with us or not? Like I don't have a strong line on that, but like people often don't save as much as would be rational as another.
So I'm gonna bring up an issue with the saving, and I think sometimes it's hard to say what's rational, right? Like if you could invest the money, but there's a chance that you lose it or something like that.
Right. There's like how much risk do you want to take on?
How much risk do you want to take? What's rational there? And then, what if you really want to live your life now and you're like, I'm probably going to die young anyway. I'm not going to worry about it, that kind of thing. And then you end up old. Somehow.
Despite all your daredevilish behavior.
I know, it was totally against the odds. But so now you've got someone who's old who has no resources. So, some people might say, okay, well, that person,
Did it themselves.
Did it to themselves, and whatever happens, we want to like vaccinate them still and prevent them from making other people's health worse. But just let it go. And I think that's always going to be true to some extent because there's always going to be resources are always limited, right? Okay. There's some care that can only go to some people. The question isn't how do you get everyone the care? The question is, well, that's one question, like how do we advance our medical resources and technology? But the question we're asking here is, how do you allocate those resources? What's the best way to allocate those resources? What does it mean for those resources to be allocated efficiently? You're deciding who lives and who dies. How should that be decided? That kind of thing.
But I think you have to answer Steve, though, because, Steve, I think what you're bringing up is, how do you get the system to be efficient?
Right.
For these catastrophic things, right? Because it's not very efficient.
So this is what I was getting at before.
Yeah.
Which is that when anyone ever talks about saving, the reason for that saving is because you need money later. Well, money later, if everyone needs it, if it's something that really is most efficient for everyone to have, if you need everyone to save, then it's just as efficient to have nobody save and provide money to everyone later, right?
Except for my point about prevention, about people being incentivized to be healthier.
People being incentivized to be healthier. Oh, right. So if you think you're just going to be taken care of forever, then that reduces the incentive to take care of yourself.
I'm not sure I think that's that big of a problem, or you could try to attack it other ways, but it is a potential benefit, I think, of Steve's point.
Well, I can...
go ahead.
Let me just recast what you just said. There's the car insurance model. Mm-hmm. You have a car accident, the insurance company gives you a lump sum that they say is enough to fix your car.
Right.
And then you shop.
That's true.
If you're poor, you don't use more than that money. If you're rich, you can top off, what the insurance company gave you. So you could do health insurance that way.
That's true.
Which is sort of like a kind of insurance rather than everybody saving hundreds of thousands of dollars.
Right.
Yeah.
But then a poor elderly person who needs a liver transplant, they just get $200,000 for it. But the average price in America is, $300,000 or $400,000 for it. So he has to shop. So I could work with that too, because they would still have to shop.
Country and have the surgery and bank.
Yeah, that's kind of interesting. That's an interesting idea.
I think that's a good point. Anna Chris.
I'd like to defer.
Defer.
Whatever. Sorry, please go ahead.
Richard.
With Alex's point before about how it makes more sense to have no one saved than to have everyone saved. In China and other, Asian countries, they have a saving culture, and so their economies have very little consumerism, and so but in the U.S. pretty much no one saves, and so we have 60-70% of the economy is consumer based, and so there's all these innovations and things, and so maybe that's the way to go. So there's more innovations and in the medical field and things like that. If they don't save, and if they do save, and there's no investments into these technologies and things.
Yeah. So Michael on the live chat brought up a good point, which is, would it be possible to, instead of hoping that everyone saves, You just calculate and, if necessary, lower the amount of universal basic income to make sure the system has the resources when people get sick. And I think that's the right answer.
So,
yeah.
something that I was going to add is that the idea here is equity happen by creating a margin, a gap amongst what the health insurance is giving you and how much you're willing to invest in your health. You are creating a huge gap in disparity. That's why I was saying, like, well, and the idea of the car insurance is really good. It works because it's something material that you could do without. You could live without. You could live without a new car, or it will be difficult, and it will affect your life and your movement and throughout and your job and whatever. But it's manageable. And when we're talking about liver, because you were born in X or Y zip code. And it has been proven that if you were born in a different zip code within the same community in Chicago, you will likely suffer from inequalities based on where are you from, your zip code. Imagine a country, imagine a religion, imagine everything. So what we want here is to create equality. And by creating equality is reducing disparity. So by saying, I will give you, as a government, I will give you free money. I will give you $200,000. Thank you. But I want a liver. How much is the liver on the market? So the liver is about $500,000. Okay, I'm just gonna call my rich friend Alex with his convention idea, and I'm just gonna get the remaining amount. But the other person that doesn't have an Alex, the other person that doesn't have anyone, the other person that has been born in a situation that reduces opportunities for this person to thrive in the future, might have equality, might have $200,000 just like I do and just like you do, but does not have the privilege of having a safety net, of having someone that could give this person whatever they need to purchase the same liver this other person has the privilege of.
So
they have to go with the liver cheaper.
I think that's a really good point.
But you're sacrificing quality.
Yeah, they are. Yeah, they are.
So what we want is equity and high quality care.
So I want to bring up a point here, which is that there are some things we can afford.
It was a good analogy. Do you say analogy?
Yes.
Yeah.
I'm having issues with my pronunciation here.
It's just that one thing we want people to know if you differ or defer.
Or concur.
Or concur or conquer.
Yeah. So I
think liver and kidney is not a good idea. Is not the best example.
Because you can't buy them; it's illegal. To
I
do
don't
so.
personally know.
I'm using these. I'm using these to signify other things. So these are.
No,
these,
it's actually it's a good point because you're not buying it, but if you don't have health insurance, the hospital will never put you on the list.
So the reason I wrote these words here is because I want us to imagine a world. So it's always possible for us. There are certain things we can provide for everyone, and then it's we have the resources to provide them for everyone. There are certain things we don't have the resources to provide for everyone. So I want us to imagine a world in which, for some reason, we've got the technology that we can provide everyone with kidneys, no problem.
Like in the future, they're making mini kidneys that you can put like a dozen of them that are equivalent to a kidney.
Sure.
Or something.
So let's say that happens. So we're in a world where we have the resources, no problem, to provide everyone with kidneys, just like we have the resources to provide everyone with food. But we don't have the resources to provide everyone with livers. There's a limited number of livers. So the question is, how do we determine who gets the liver, right? So we're talking about, a situation in which the rich person could get the liver, but the poor person couldn't. What's a better way to allocate the liver? Maybe you can. Yeah, I mean, you can look at other variables like, did the person lose their liver because of alcoholism and they're likely to lose it again? Maybe that's not the best investment of a liver. Yeah. Is it a young person or an old person? That kind of thing. Yeah.
I guess all those things. Why? I guess what are you driving at with it?
I just wanted to make this distinction between, so there's healthcare that we can actually provide for everyone. Like Anna Chris was saying, Declaration of Human Rights, healthcare should be free by the year 2000. Well, of course, that's impossible if you're talking about like the latest fancy treatment that was
that wasn't the case.
Right.
We're in 2020, 2019.
Right. But I mean, the question is, so in order for that to be possible, you have to define a a subset of healthcare that's actually possible to give to everyone. So that's what I'm representing by the kidneys here. So I've just kind of like drawn.
And I think importantly, with why we're trying to even discuss how to make things more efficient is so that everyone can get more healthcare. Because the idea is like if healthcare becomes really inefficient, people don't get as much.
I think that the most important is to focus on just basic primary health delivery, primary care delivery. That's the most important thing.
Yeah.
Yeah.
And
that's free.
We have the resources to give that to everyone. So that's mostly
preventative.
That's mostly.
No, it's routine and
preventative. It's mostly these two. It's also some of these. Like there's some catastrophic care that we do have the resources to provide for everyone. It's just that people won't naturally, save up the resources themselves. But there's like fancy experimental treatments or whatever that only some people can afford. But I think Anna Chris, you're right. So the question is, how do we allocate the stuff that we know we have the resources to allocate? Do we make it free? We could make it free. Is that the most efficient way to do it? If you have, a routine doctor visit or something like that, and that's free, then what's to stop people from just going in all the time and actually using up more of the resource than is necessary?
Where does the money come from for the equipment and the doctors and?
I'm talking about resources, right? So we have the resources. That means
basically, you might want to frame it, Alex, as like, should you take people's basic income away and give them like some of their basic income away and give them the medical and use that to cover the medical care?
If we're using the resources to provide the healthcare directly, that means that's resources that are not going into the market that could be that people could use to buy things from the market. The alternative is that we can give people the basic income, and then we know because they have an incentive to take care of urgent things and take care of routine stuff that they will buy it for themselves. Then that should be fine too. And it's not going to be super expensive. It's not going to be because we have the resources to do it. Right now in our healthcare system, it might be really expensive, but it's not because of lack of resources. It's because of all these other inefficiencies with like the health insurance system and all of that.
But I like that, and I also want to go to your point, Steve. Like, could you get some of the same benefit without giving people like half the cost that they need, but basically giving them like pretty much the entire cost, but then they could like save a little bit extra? Like, I still kind of like this idea of like for catastrophic, like you give them the money and they can allocate it to the hospital instead of it being paid but then you just maybe would want to give them the full amount basically that they would need. Wouldn't that still drive down costs eventually?
So what are you saying? You just give them the money and then they decide which hospital to go to?
I think your point, Steve, was maybe, correct me if I'm wrong, because I might be thinking of something else, but I thought the idea was like, right now if I need a liver transplant, or let's say like something that's less limited than a liver, but like let's say I need like a surgery or something, they just reimburse the surgery, but the hospital gets to set the price, and no matter what that price is that the hospital sets, they reimburse it.
You're saying right now?
Right now.
Yeah.
And I don't get any like extra money for going to a cheaper one or anything like that.
Right.
But it seemed like an intriguing idea, at least to me, to think I hadn't even thought about before. Like, what if they basically took what if it was the average price across hospitals for or good even higher than the average price? It could be anything. Yeah, like the value of the car, and then like maybe I get to keep the extra money if I decide I want to go somewhere like a little bit cheaper. That might ever so slightly like start to bring the cost down, and over time they might go down.
So I think that's a good idea for some things. I think some catastrophic care is urgent. It needs to happen right now, and the hospital you go to is right. The hospital you go to is whichever one is closest, right? I mean, like that's your only choice. I think there's some stuff like you're waiting for, like a transplant or a specific surgery or something that could be effective for those types of things.
Yeah, I guess you'd have to think carefully about like which things.
It's not like
if there's no choice, it doesn't.
If someone calls 911, you want an ambulance to come, not a pile of cash. Yeah.
It would depend on whether you have time to actually make a choice, I guess.
Right.
Yeah.
So I think,
But there are lots of things like cancer and stuff where you have some time to like choose between hospitals.
Yes, absolutely. And, you might even, make a choice based on price too. Like maybe the fanciest
You're leaving us?
Thanks for coming.
Oh, okay. Yeah. Did you have any last comments before you leave?
Closing thoughts.
Here's my comment.
Yeah.
Actually, I saw it today and took a picture of it because I thought that it just has everything. in it. And this is in the wall at Harvard School of Public Health. And it says, obtaining the highest attainable standard of health is one of the fundamental rights of every human being. And it's written in every single language.
Oh, cool. Where you saw it around town?
Harvard School of Public Health.
Oh, neat.
Obtaining the highest attainable standard of health is one of the fundamental rights of every human being.
Cool.
I will drop mic, and I'll see you guys.
I'll see you at home. Yeah.
In a little bit.
See you later.
Yeah.
This is a good talk.
Yeah.
Oh,
thanks
thank
for coming.
Cheesecake.
Thanks for coming out.
Yeah, thanks for
Sorry
coming,
I'm
Anna
running a
Chris.
little bit later,
Yeah.
so
Oh, that's all right. We're glad you came. Yeah.
That's fine.
See you soon.
Yeah, Richard, go ahead.
Well, here's an example of how insurance can be detrimental, or not. In The Sopranos, the main character Tony was shot, and they did a what they call it, wallet check or something like that for his insurance. And if he didn't have insurance, he would go to this hospital. He probably would have died. And there's the other one. He went to this really state-of-the-art hospital with all these surgery and things, where he would have survived, or he actually did survive. And so it's determined on if you have insurance or not. And so, or it could be in the future if they actually have some sort of like a system where you have different levels of insurance or something like that. It could be that can just decide of where you go or whatever.
And so I think this brings up like two important questions that we've been talking about. And like one is you were asking like, how do you allocate the scarce things? And people generally don't like the kind of arbitrariness of how it's allocated now.
Oh, what's allocated?
Arbitrariness, like of the quality. Like he's saying, like if you happen to have insurance or you came from a better zip code, like she was saying.
And they also don't like someone deciding
Right.
who gets to live and who gets to die.
They don't like someone officially deciding, which then can make it even more inefficient. But I was going to bring up another thing, which is like part of what we're talking about is like trying to figure out to what degree is the system just like set up poorly, and we actually could have had both of those hospitals be good, versus like we actually don't have the resources to have both of those hospitals be good, and we have to decide who goes where. And so I think that's like part of what.
And that's about allocating the resources
socialized
efficiently.
medicine is now suddenly making much more sense to me, because the level of care, the variation in level of care in America really has to do with the system that we're in, the capitalist system, and profit making, and that everybody can get into anything really at various levels and work to be the best or not, the best doctors from the best schools, or maybe not such a great school, but they can still be a doctor, and maybe it's not such a great hospital, but they can still be a hospital, and they're still making money. And that creates this whole patchwork that's dangerous for people. It's fine in other products, but the product of your own health, it really doesn't make sense the more we're talking about it.
Yeah, the stakes are really high. And also just empirically, like our system, it's not even working well the way like markets work. Like that's kind of what we've been talking about. Like it's just super inefficient. It has all these problems. So we're like paying more, the quality of care is worse.
But even if we had transparency and we could see the operations of all of them, I mean, we have a little bit of that, and we see that people with money will go to Mass General if they have a chance. I mean, they'll travel to Boston. A friend of mine just went from New Mexico to Mayo Clinic. I mean, they're not going to get what they want in New Mexico. So, and they have money.
So travel and stuff.
So if if we already know certain things about levels of health care in the country.
That's a good point.
And we already know that if you don't have enough money, you're not going to get the best health care. So even if all of the transparency was there, we might see when it was transparent what we already kind of know from the outside, which is, Mass General has all the best equipment, has the best doctors, it has, we knew that. So how does that make a difference to people getting health care? In a way, it just means, I have to go to the cheap one. Like I have to buy my cheap stuff at the dollar store, like everything else.
So I want to bring up another thing about efficiency, which is that in India, for their hospitals, they have kind of what they call a hub and spoke system. So in the big city, there might be a big hospital that does all the special stuff, but you only go there for the special stuff. And the doctors specialize on their special things. You don't have doctors, here we have doctors filling out forms and doing paperwork, and, really doing things that are not directly healthcare.
Right.
In India, no, that's not the case. So if you have something that can be, if you have a condition that can be handled by one of the
Clinics.
spoke hospitals, yeah, like a clinic. I guess the clinics are analogous here. Then that's where you go, and you don't see a doctor who can perform this really special surgery. You don't see him for something routine.
Right.
He focuses on that.
Right.
So that's a potential area of
That's
efficiency
efficient,
too.
yeah.
Yeah. And if you can imagine something like that developing when we have more transparency, you can imagine Mass General becoming one of these really specialized places that, there's no point in even taking a patient who, needs something routine done, because actually that thing could be done just as well
Anywhere.
at one
And
of the
that's
lesser
inefficient.
hospitals.
Yeah.
Yeah.
Right. Yeah.
You raised two other. Were you done?
Yeah.
Two other interesting things for me. One is that with a basic income, you'd have a little bit more ability to travel or even just take the time, like we talk about, to research the different
Time off.
hospitals and even
time off
know,
from work.
or take time off from work. Yeah, any of those things. But also it doesn't seem like it would take that much to just research the hospitals. But like anything else, if you don't have time or resources, you're probably not even doing that as much, let alone traveling.
Right.
So that would be ameliorated some. And then the other thing is we've talked before in here about price elasticity of demand. One potential problem with trying to let the market get the prices down is a little bit what you said. People might, for their health, to some degree, be willing to pay anything for the best care. So that might work against. You know this better than I do, but that might work against the prices coming down to some degree.
Well, I mean, it's kind of a microcosm of, if you're giving people too much basic income. But if your basic income is kind of calibrated at the level the economy can sustain and healthcare just ends up being more expensive, yeah, it might be true that everyone is going to pay what they can for it, but, then you're in a situation where some people can pay and some people can't, and that's who gets the thing.
But I'm wondering if it would be more efficient than to have a government supply it and try to supply it at cost, because people otherwise they might be able to drive up the price because people will pay anything because it's their health, right?
Yeah. So the question is, what do you mean by at cost? If it's a specific, if the resource is constrained, then the cost is going to be determined by that constraint.
Yeah. So it depends. You'd have to decide how much resources.
If you can provide things at cost, then the price can be.
Well, you maybe take that part out of it, but I'm wondering if it's possibly more efficient for the government to provide it.
I think there might. So then what's efficient? Who gets the treatment? That kind of thing, and maybe it should be determined by more than just money, is what you're saying.
Well, I guess I'm trying to figure out how price elasticity of demand relates to what we've been talking about.
I think for something that people absolutely 100% need, they'll spend all their money.
Yeah, exactly. Yeah. So how does that relate to how we should handle healthcare?
You're saying that maybe you would prefer people to... Okay, you would prefer people to be able to save their money and get the healthcare anyway? Is that what you're saying?
Well, I don't know. I'm trying to think through how this affects it.
It affects it by driving up the price until only the people who can actually pay.
What affects it? What do you think?
The inelastic demand. So the fact that people are willing to pay whatever it takes to get the needed healthcare.
Yeah.
And if we're saying that this is a scarce thing, this is then the price of that is just going to end up being whatever price.
Willing to pay the highest.
Well, not just the highest anybody's willing to pay, but it's going to be the highest that the last person is willing to pay.
So
say there are 100 people who can.
So it seems like that would lead to two problems.
Yeah.
At least one problem.
Yeah.
One problem is that we don't tend to like people's life and death being determined by their wealth. So that would mean that life and death was determined by their wealth. And two, I don't know, but given your various drafts, it's possible that it could actually lead to fewer people having that, because it might be better to provide fewer of them at a higher price than more of them at a lower price, like we look at with other products, which is really bad for healthcare.
So I see what you're saying. So you're imagining kind of a steep drop in demand
because of people's wealth being very skewed. Yeah.
So maybe there's a cadre of wealthy people who all get it, and they could have provided it to twice as many people, but nobody
they would have
else
had to charge less. Yeah. I think that's a problem.
I think that's a reasonable concern.
So to me, that would mean those kinds of things should not be allocated by the market.
So how do you handle that?
Well, you can allocate them by the government and then have another system for deciding who gets them.
When you say allocate them by the government, that still doesn't answer the question. Like what
How do you
factors
decide
should the
who gets
government
them?
factor in?
Yeah, probably
and,
the same vague things they do now. I mean, it's not going to be perfect, but like you said, like how many years does the person have left to live? Like, are they going to have the treatment be successful or not? In expectation. That kind of thing.
This assumes that
Yeah.
there's a fixed amount of whatever livers.
Right.
Is that appropriate example?
Yeah, I think we're trying to talk
okay.
about those. Yeah.
I still don't think it's a good example. The reason I brought up livers was because, as Richard said, you can get a liver transplant for like a quarter of the price in another country.
Right.
So there's a global market
Right.
that has lowered the price for a lot of things,
That's a good point.
a whole lot. So that's a standard example. That and cosmetic surgery and laser eye surgery are the standard examples for when there is some market competition, the price really does go down,
Yeah.
and the services get better.
Yeah.
If we're talking about livers, you're assuming that the supply side is not going to do anything to serve even people who have money and are dying. I'm gonna say that that American capitalism really will notice people with money who are dying and try to serve them one way or another.
They're making mini livers too. They're making all sorts of
Why
mini.
are they making these mini organs?
This is great.
Out
Yeah.
of what? 3D printing? What are they?
Huh.
And they're also like hearts too.
Yeah,
Like
I've
they're-
heard about the hearts.
Like they were making out of spinach leaves and things like that.
So cool.
Yeah. So, but let's imagine there is a scenario in which.
Yeah, I
Sure.
wouldn't have even come up with this thought, Steve, unless I had looked at a lot of Alex's graphs already. But I might be misconstruing. But like sometimes, if you can only set one price, which maybe you're saying they would like find ways to set like different prices for different qualities
I don't think
of
that's
services.
what you're saying. I think
but-
you're saying.
Well, I'm saying that the supply side would attempt to do something or other.
Right.
Make mini livers.
Right.
Mini livers, fake livers, artificial livers that are
Right.
very cumbersome and they're outside your body.
Right.
But-
Actually, a liver is a liver.
But sometimes.
So I think you're right. The supply side is going to do everything it can do to
Okay.
make the profit.
Yeah.
Right.
But then the question is, what if the supply side is facing real resource constraints? So that's kind of like the thought experiment that we're going through. Like there are certain things the supply side can't do. What if there are things they can't do even if they
Yeah,
wanted
but
to?
we're supposed to say that.
Yeah.
And you're supposed to disagree with us. Because the standard criticism for UBI is, everybody's going to get money. And then the stupid critic says, but the supply side can't respond, even to make money. And so inflation will take off.
Yeah, but I also frame it as there is a certain productive capacity of the economy, and we need to calibrate the basic income to that. Beyond that, there's resource constraints. So, there's always going to be the question of how do you handle being up against those resource constraints. So if you have a calibrated basic income, that's activating the economy's full productive capacity, then magically Say's law actually does work. That supply does create its own demand because as soon as you have more supply, we'll give people more money to activate that supply.
Well, but are you saying in general that the supply side really can react to all these poor people who suddenly have money? Or are you saying not so much? A lot of critics pretend that capitalism doesn't work at all, and the supply side can't do anything about it.
What I'm saying is that there's a degree to which the supply side can respond to people being able to spend more money. We don't know what its capacity is. We find out the capacity by calibrating the basic income. Some people might argue that the calibrated basic income would end up being very tiny. My intuition is that it's not, that it's going to be, fairly sizable, probably more than $1,000 a month, at least in America. And that, I have, various evidence for that, but, it's still, it's true that the economy can only produce so much stuff. The question is, how do you get it to do everything it can do?
Yeah.
And that's what we want here. We want the healthcare system to do everything it can do, maybe with saying, if we're trading off resources from the healthcare system and other parts of the economy, we have to make decisions about that and that kind of thing. But, there are real resource constraints. There are always going to be real resource constraints. And we're using the example of a liver, but I could use an example of, some, new technology that costs $10 million to do one treatment on one person or something like that. The reason it costs $10 million is not that we could provide it for everyone if we had $10 million for everyone. It's that there's a real limit. We've only got one of these machines, and it takes 60 days to do the treatment or something like that, right? And the supply would respond. You'd want to improve that.
And like
Laffy, the first hamburger, or not hamburger, hamburger cost $200,000, but now it's down to like $30 or something like that, and that's just in like 5 years.
That's pretty good. Yeah, so I am hoping to have all of these kind of medical advancements and to incentivize them and to keep improving things. I think that's great, but there's always going to be resource constraints, and that's true. I say medical advancements, but that's true of technology in general. I want us to be more efficient and more productive, and get better stuff for everyone all the time.
I understand that it's taken 6 months, but I found a place where you don't think UBI is perfect, is the perfect solution to everything.
Healthcare. Is that what you're saying?
Well, and then you have to. So if I were the critic now, I'm totally changing sides.
Yeah.
If I were the critic, I'd say, oh, well, if it doesn't work, if UBI really doesn't solve healthcare, then is UBI just good for, dollar store crap? But can't actually help with anything important?
Yeah.
Well, Alex has been consistent on this all along in a way, because he says that UBI funds the things that are the market handles best, and now we're kind of debating which things go in that category. Right. And we've never said everything goes. He's never said everything goes in that category, but now we're kind of breaking down healthcare into even maybe different parts. I don't have a full answer to which goes in which category, but I think that's the discussion.
Yes, and I've often brought up examples of things that for which it's more efficient for the government to allocate the resource directly, like
building
infrastructure,
a road or
providing military, that kind of thing. And one of the examples that I often bring up is actually healthcare. But what we're getting into here is that it's a little more nuanced, and maybe there are certain aspects of healthcare that can be efficiently allocated by the market.
Right.
And that's where basic income comes into play, because basic income funds the resources that are most efficiently allocated by the market.
And I also think that everyone here thinks that a lot of gains could be made and a lot more people could be getting a lot better healthcare.
Right.
It's not like we think I don't think it's zero sum, but then we just try to also wonder what about the really, usually in the regular market we're kind of okay with richer people getting the scarcer things. The yachts, whatever. Right. Don't care so much. Right. But healthcare is, for some people, a little bit different. And it doesn't have to be for you, but it's we become more concerned ethically. Do we really want that to be the way that these treatments get decided?
I like that you brought up, Steve, I like that you brought up the example of cosmetic surgery. So cosmetic surgery versus liver transplant. Yeah. We feel very differently about these two things.
Yeah,
to what extent should they be allocated using similar mechanisms, and to what extent maybe not?
Yeah.
Is the cosmetic surgery for a cleft lip versus I need a larger buttocks or something?
Yeah, and that's also true, right? Yeah.
It gets into these details. Yeah, it's true. So, and it's tricky because it becomes an ethical or moral question of where do we feel comfortable with things being allocated one way or the other.
But one could argue, I'm changing sides again, going back to my original side. One could argue that the moral problems are irrelevant because the cost of medical care is going up to infinity. Whatever, no matter how nice we want to be,
right,
or how high we want to raise taxes, the cost is going too high, and we have to figure out a way to lower them.
Right.
Now you could just start with that's the problem.
Right.
That's problem number one. You have to start lowering medical costs. If you don't want to start there, then
right. I think we do, but I think we're again looking to the resources versus and trying to separate that from the price. Because part of it is they're not using infinite resources for medical care, but like you said, the actual dollar prices are going totally beyond what even makes sense. So there's kind of both problems. They are using resources really inefficiently too, and the dollar prices are really high.
I think there's a lot of things at play that are causing this inefficiency and causing prices to go up. And I think kind of big picture view, we have a system where we want to give something to everybody. There's a certain thing we want to provide for everybody.
Right.
We don't have the resources to provide it for everybody, partly due to the inefficiencies. But you can imagine this happening even if we were as efficient as possible. We're like, we want everyone to have this form of care that is resource constrained. Prices just go up. Because you keep putting more money at it, but it's chasing a constrained pool of resources.
But to me, the most striking problem, well, there's that, but there's then, that's I guess the dollar amount thing I was talking about.
Yeah.
But there's also like just what Steve keeps bringing up is like, we don't have a system that naturally has the right pressures on it to be efficient, like using even resources efficiently or like be as effective as it could be.
Right.
And that's a big problem too.
Right.
And how do we fix that?
So there's the question of how do we achieve that, and then there's the question of once we've got this efficient system in place, how do we make sure that we're not trying to overspend and activate more capacity?
But I'm getting tangled up because it seems like sometimes our solutions to what would help one hurts the other.
Well, this is part of why I don't start with the problem of prices going up. I start with the problem of resource allocation. And there's some things we have the resources to provide for everyone, and there's no reason why we shouldn't. How do we do that as efficiently as possible? And then for the things where resources are constrained, how do you decide who lives and who dies?
But that leaves out making the system use resources more efficiently, which is also a really fundamental thing.
Well, this is the question: or it leaves out how to make the existing system use resources more
or
efficiently?
Whatever your system is.
I mean, these questions are questions of efficiency, right? These are the questions I'm asking.
Okay.
How do we make it efficient? How do we allocate resources efficiently? Yeah, Richard.
Well, there's actually a law that Medicare is not allowed to collectively bargain for drugs and things like that. And if it did, prices would go precipitously down if they were able to do that. Like with the military, their prices are much lower than Medicare and other things because they're allowed. They can build their own things like that, but their own facilities to serve veterans and active military personnel and things like that.
Yeah. What when you talk about resources, what do you have in mind? Medical resources. I mean,
how many doctors? How much equipment?
I mean,
how many materials do you have to produce the drugs and that
I guess the research that goes into it.
The research. I mean, it's less about. So when I'm talking, it's less about research. So that's another question. How do you incentivize innovation in healthcare?
Which is a big part of these things we're talking about too. Yeah.
Right. But then I think mostly what we've been talking about is given kind of what we have in front of us.
Right.
What we have available to us, how do we make sure it benefits the most?
I know you want to focus on how to distribute constrained resources, but I'm also kind of coming over to Steve's point. When I think about the resources involved in healthcare, it doesn't make sense that it's so expensive. Building a house takes a lot of resource. An MRI machine doesn't take that many resources to build versus a house. We don't seem to have this kind of problem with thinking building housing is scarce. Maybe I'm just confusing myself, but it seems
so there's a few things to keep in mind.
Resources aren't that high.
Well, there's a few things to keep in mind. One is that a lot of times I'm talking about these kinds of experimental treatments, stuff that not everyone can have. So there's that. And then another thing is the old people problem, right?
Right.
Old people, as they get older, they're going to progressively take up more and more resources,
right.
And that's not it's not oh yeah, we can keep everyone perfectly healthy with the health of a 20-year-old throughout their entire lives.
No. I'm just saying, I think a lot of what the healthcare system looks like in terms of feeling resource intense might actually really be about these dollar prices, because the normal care that most people get isn't actually taking up that many resources.
I think you're absolutely right.
It's insane how expensive it is relative to
yes, we can provide people normal care fairly easily, and
almost everything that comes to mind, including chemotherapy.
And you should be able to have most routine care. It should be affordable with a basic income. That should be achievable. We have the resources to provide everyone with that.
Yeah.
That's not the complicated problem.
But I think the complicated problem is how do you get the system to be more effective or less expensive or more resource efficient and that kind of thing.
Yes. So given the system we have now, what are the things we can do? What are the measures we can put in place to make it more efficient? So I think. Yeah, I'll get to that in a second.
Okay. Yeah.
So one thing we can do is implement a basic income. So that could be a step. Once you've done that, we don't have to feel guilty about charging people a nominal price unconditionally. You got to pay $5 if you want to use the emergency room or something like that, right? So that's one step, right?
It's fine, but I don't think that hits like the major issues.
It's pretty big. It's charging a nominal amount for we can ask what the efficient amount is to charge for various services, but charging a nominal amount, there's a difference between charging nothing and charging something. That makes a huge difference in resource waste.
My guess is like if you could pick two things, it would be like not limiting the number of doctors and funding research by the government and not having like copyrights. Those would probably be like two big ones.
Well, I'm not trying to pick two things. Let me just quickly, I think the other two you brought up are important. Not limiting the number of doctors. That is, absurd. That's a resource constraint that doesn't need to be as constrained as it is.
There's plenty of people who want to be doctors.
There's plenty of people who want to be doctors. And then what was the second thing you said?
Oh, the whole patent thing on like all the medical equipment, drugs.
I think eliminating patents, obviously in order to have innovation in medical technology and pharmaceutical research, you need to fund it. And if you eliminate patents, that changes their funding model. They can't fund it by anticipating future profits, right? But that doesn't mean it can't be funded, and it doesn't mean that, funding it maybe directly by the government isn't going to necessarily be better for people. I think it potentially is. In a lot of ways, pharmaceutical companies and medical equipment companies are curing rich people's diseases because they're the ones who have the big bucks. We want to cure everyone's diseases. So I think eliminating patents would be pretty huge. Yeah, Richard.
My grandmother told me about when she was the head of a senior center and about how they had this like senior buses for people to appointments and things, and then how there was this doctor who took advantage of the seniors' forgetfulness and had them go to see him every few days, even though they could have just seen him every month or something.
Oh, no.
And so they just racking up fees and things like that. But if they had like a $5 nominal charge, then the senior would notice that because they don't have that much money,
right.
they would notice, I'm spending $15 this week just seeing this doctor, and they would.
Right.
Yeah.
It's an interesting story.
It's true. There's a lot of disconnection between, where the prices are being set and where the service is being provided and who's making the payments. So you can easily have a situation where the insurance is like, okay, that looks reasonable, but if the patient actually knew what was happening or something like that, then it wouldn't. You wouldn't have that kind of problem.
Did you want to get to Michael's?
I do. I just want to bring up a couple more things that we can do to make the existing system more efficient. Not tying healthcare to people's jobs, not forcing people to get their health insurance that way, and providing insurance kind of single payer through the government. Like there's always going to be, private companies that want to provide some sort of premium service or something, but we can do plenty at the level of the government. We can provide people care for all kinds of catastrophic things and all of that. So I think those 5 things we listed are each things that could improve.
They still don't solve like Steve's point of like the kind of systemic lack of competition in the system.
Well, I think in the article, the stuff he brings up in the article can help with some of that. More transparency. This can be challenging because of privacy issues, but
you can have aggregated data. Like it's not so.
Well, more transparency, and then also seeing what the prices are. Mm-hmm. So we're talking about insurance and catastrophic stuff for what the government's going to provide, but the routine stuff you could pay for with the basic income. And we talked about a $5 nominal fee, but there might be more efficient prices for those things.
Right.
And then you could have hospitals and doctors compete on price.
Or similar to like your plan, Steve. Like you could even have the insurance company or something bonus people a little bit, like for going to like the cheaper hospital. Or paying attention to prices?
I think you could for the things that would make sense to be covered by insurance. But I think routine stuff, the market can allocate that. Yeah. Richard?
There's actually a conservative plan where they have these little clinics in like malls or whatever, where they have
urgent care.
Nurse practitioners instead of doctors look at patients, and then if there's something beyond them, they would send them to a doctor. So there'd be like instead of a hub and spoke, and then there's an extra layer beyond that with an extra wheel or something instead of the spoke.
It's a good point. And like de facto, this is happening a lot where like nurse practitioners are getting PhDs even, and like they're basically taking into the role of being a doctor to get around these sort of limitations. The system clearly needs it. I see them interchangeably when I go to like the clinic. I'll one or the other. It doesn't even matter.
So I think it makes sense to lift some of these restrictions on how many doctors we can have, but I think this also makes sense. Even if you let a lot of people have doctors, there are some things that we don't need a full doctor's training to be able to treat. So we can really...
And we haven't even gotten into like automation and computer algorithms and how that can help diagnosis and all these kinds of things.
So I want to get to Michael's points. His first point I wanted to get to before and I didn't quite. So I want to do that one first. So he said, would it be possible to, instead of hoping that everyone saves, you just calculate and, if necessary, lower the amount of universal income to make sure the system has the resources when people get sick?
Oh, we did talk about that one.
I said I think that's the right answer, but I want to say more than that.
Oh, okay.
So this is the right answer because the care you're going to be able to provide has nothing to do with how much money people saved. It has to do with what resources are available right now to your medical system, right? To your healthcare system. If someone saved, $10 billion over the course of their life, that doesn't, set aside $10 billion worth of resources for their care in the economy, right? And it's the same thing with Social Security. Like, we pay people Social Security. What makes that possible isn't that they, paid their Social Security tax. What makes it possible is that there's something for them to spend their money on, right? So it's all about resources right now. So instead of having everybody save, it makes more sense to think about how many resources do we want to allocate right now to old people. And maybe part of that is just old people have basic income and whatever resources they get. Or maybe we do want to make a decision to say, old people are more fragile. We want to give them more care. We want to put more resources into old people. There's a limit to how far you can go in that, because eventually you're getting to a point where you're putting in resources to old people and it's taking away resources from younger people or healthier people or that kind of thing. So that's a tricky situation too. But I think generally the right answer is not asking people to save, but figuring out how to allocate the resources now. And if you want to put resources into, ensuring old people's health, then maybe that means a lower basic income right now, because it's about the resources that are available right now.
Could you say that that the universal basic income is really $2,000 a month, but we immediately take $1,000 back for the medical insurance system?
You could say that.
Okay.
Or you could say it's really $10,000, but we take $9,000 back and give, 1,000 of it to the old people healthcare system and 1,000 to roads and 1,000 to...
I think medical insurance of $1,000 a month, I think, is a real average figure.
Yeah. I probably, so you could say that. I probably wouldn't frame it that way. I would just say, as with any government spending, it's like, well, what resources do we want to allocate? If we're allocating resources to one thing, then we're not allocating resources to another thing. So if we're allocating resources to building roads and bridges, those are resources that are not available to the market, so that means the basic income is lower. If we're allocating resources to providing healthcare to elderly people, then that means those are resources that are not available to the market. Maybe the basic income
My
is
personal
lower.
sense, maybe you disagree, Steve, is like from a marketing perspective, people would rather think, oh, I'm getting $1,000 a month and I'm getting free health insurance versus like, oh, do I want to pay half of my basic income towards health insurance? Kind of seems bad, whereas the other one seems good. Like I'm getting a free thing and another thing. Versus like now I'm being forced to pay $1,000 a month for health insurance. What if I'm young and I want to pay less?
Right.
So I guess I feel like framing wise, I'm kind of with him, but I don't know. Maybe other people would see it differently. Maybe it's just because I'm on the younger side and I would think, do I really want to pay like that much? Kind of thing. Yeah, I don't know.
So I'll get to Michael's second question, which I think is kind of the crux of what we've been talking about. So he says, so is the question, should healthcare be on the market or be more like roads, since everybody wants healthcare, but not everyone wants or needs an Xbox?
Yeah, that's a good question.
And I think what we are, or kind of my feeling here, is that it depends. Certain aspects of healthcare can be more market-based, and then certain parts need more government intervention or need to be provided. Either at least the insurance needs to be provided probably by the government. So that's kind of why I broke it down into the preventive, routine, and catastrophic. The routine stuff is stuff where the incentives are such that if people actually do have money, they're going to buy it for themselves. So healthcare is something that people need, as opposed to an Xbox. But there are other things that people need, like food, that are perfectly efficiently allocated by the market if people actually have money to spend. So there are certain aspects of healthcare that are like that. And then there are certain aspects of healthcare that are more like, I don't want to say roads and bridges, but maybe more like the fire department, right?
Yeah,
it's going to put out everyone's fire. Whoever has a fire, it's going to put it out. And that's a piece of infrastructure that's available to everyone. So it's both. And it's really tricky to kind of figure out what goes where and to make decisions about, these are people's lives and how to allocate these resources. Yeah. So we're getting to the end. We didn't get into the article.
Should we do a quote? Let's do a quote.
Let's do the last quote from the article.
Okay.
I think. Yeah. Macri doesn't oppose efficiency. He just understands that insider-designed processes inevitably become rigid and unresponsive. So he invents and empowers something new for healthcare, real consumers. Macri's transparency would spark the rise of the Zagots and TripAdvisors of healthcare, of the informed and the angry consumer, and of the embarrassed and responsive providers.
Sounds great. That's what I like.
It's our only real hope of getting our hospitals to perform and innovate as effectively as the Cheesecake
What
Factory.
is this God?
Oh, it's
Like
about restaurants.
restaurant ratings.
Rating
Yeah,
restaurants.
restaurant
like
rating.
Yelp of restaurants.
It's Zagat, I think.
The Yelp of restaurants, right?
Yeah.
Yelp is the Yelp of restaurants.
It used to be like a physical book you would buy, and it had like experts in it. I think, reviewing.
So I want to point out, like he talks about the Cheesecake Factory a lot in this article and how they have 300.
That's why the cheesecake.
Yeah, they have 318 menu items, and
They do. It's a lot.
and they're very efficient in all their processes. And the reason they're efficient is Olive Garden. They have to compete with Olive Garden, so it's a market incentive. But really, within Cheesecake Factory itself, there's no like market competition within there. So it's so at one level there's market competition, at another level there's central planning within the organization.
That's cool.
So the 318 menu items that are all produced very efficiently, it's marvelous, right? I would say that everything on the Cheesecake Factory's menu falls into the routine category.
I was going to say, because
That's why it's easier for them.
Yeah.
And for the stuff that falls into the routine category for healthcare, all of this is going to make it more efficient and better off.
Right.
And maybe transparency and figuring out how to add market incentives, how to make preventive care more routine, how to make catastrophic care into preventive care, into routine care, that kind of stuff, that can all help too. But the healthcare system is more complicated than Cheesecake Factory. Go ahead.
I think there's also a role, like, even if something is covered by insurance, for competing on things other than price, like we talked about, which are ultimately part of what we care about, big part of what we care about for healthcare. So, like, if you add transparency, it's as long as it's not like something like, well, actually, even when I was in an ambulance one time, I was conscious and I wasn't that hurt, but they gave me a choice because I'm in a city of multiple hospitals that were close by. Like, if I happen to know anything about those hospitals, like, there often are choices for these catastrophic things.
You couldn't check on your phone.
Yeah, if you have
I didn't have my phone.
But you could anyway.
Oh, yeah, that's true.
If they handed you a tablet, right, and it had all the hospitals with all the prices and also like the ratings of their different kinds of care.
Like Amazon
this is the treatment that you need. Here's the ratings of these different hospitals and doctors.
That would make a huge difference.
Yeah.
I mean, huge difference. And people do use this for some things, like you were saying.
Yeah.
They look it up for like different kinds of needs and
Outcomes.
outcomes and stuff. Yeah.
So let's get final thoughts about healthcare and basic income. You don't have to weave in basic income if you don't.
No, I guess I'm still like curious about what would actually be in this routine category and how would that work.
You get a cold, go to the doctor.
So that would just be something we pay for.
Yeah.
Flu.
Yeah.
Yeah.
So I guess
like getting your car repaired, right?
I kind of like this idea, but I also very much, it's hard for me to like even focus on your idea, because I get so stuck with how like inefficient and overly expensive the current system is. So I'm thinking like, how much are you paying? Like, you know, I'm imagining the routine, but like in current prices and current incomes, which is not what you're talking about, and it just sounds really bad. So I have to kind of like try to get myself out of that frame of mind.
Right. If we know we have the resources to provide it for everyone, then there's no reason why the price can't be something exceedingly affordable.
And we'd be getting more income. So, you know, I guess that's all important.
Yes.
But I guess it's interesting, like, how you would figure out, like we talked about, kind of how to handle these different categories and what's in the different categories. So, for example, like, pregnancy is foreseeable. So some people argue it should be in that routine thing. However, there's, like, a social externality. If you don't get good prenatal care, it affects your kid forever. And then that affects society. So there's just, like, that's just an example. But there's a lot of issues where it wouldn't really be clear where to put something.
Yeah, and I think that's right. And these aren't discrete categories, right? There's stuff that falls in between. And as you get older, maybe stuff moves from catastrophic to routine, you know, that kind of stuff, like Steve was saying. So it's more nuanced, definitely, than kind of the picture I drew on the whiteboard.
It's interesting.
Yeah, so I was really most interested in the idea of transparency and how it could be attained, and how then we could make decisions based on it, like in the ambulance. Can you look it up? I mean, it's true that there are things that we know about from hospitals, and you mentioned pregnancy and, you know, numbers of pregnancies, or doctors. You can look up doctors sometimes. In the Boston magazine, they have all these graphs and stuff about different doctors, how many operations of this kind they're performed, and usually if they're performed a lot more, then they're more experienced, so you want to go to them, and, you know, what are the outcomes and so forth, and what do the consumers say. But there's not so much about the people's opinions that you want, like we have in Yelp.
There's also no price transparency.
Price transparency, and we just ask our neighbors and friends about the doctors, and have you been to this hospital and this and that. It's so low level, really, compared to every other product that we try to consume. I mean, we're really on top of everything else, you know, yard work and fixing the house and all the stuff that really isn't that important. And why don't we have a way to kind of crowdsource our most important thing? Is a Netflix documentary called Diagnosis. You should really see it. It's great. I mean, it's based on the New York Times column. Doctor who asks for people, they can't figure out what's wrong with this patient. And people write in with their opinions. There's some are doctors, some are people who maybe know somebody, or some, you know, it's all these different. So they turned it into a series where they have the video clips of people talking about what they think it is, what it might be, you know, and it's it gives you a sense that so many more things could be transparent in medical land. And so many more things then could be solved. Because the people that ended up solving the problems were not people in this patient's area, maybe somebody from India, maybe somebody, you know, that they would never, ever run across. And it wouldn't be in any medical records that they had access to.
I'd love to have a website like Quora for doctors. So doctors just go on there and like, I have this patient. Have you guys seen anything like that? And then other doctors go on and they get rewarded for answering questions correctly.
Absolutely.
That kind of thing. That'd be cool. Steve?
I have two thoughts. One is, I think Richard and I defended the market approach as in the article that we forgot to read. The one, there's one really great way to separate the rich people from the poor people is the infamous waiting time before you can see a doctor, like they complain about in Canada and Europe. Can create, you know, for rich people, no waiting healthcare system. For poor people,
fast pass thing.
It would be nice if we could set appointments.
What do you mean set appointments? No, he means like how far away your appointment is in time. It's not like you're just waiting in the waiting room.
So Rush Limbaugh will complain. In Canada, you have to wait 4 months for some procedure. Well, we'll just have that be the poor people's American system. Is you get on the end of the line and you have to wait, and nobody live that long, and all the other problems. But then there'll also be the rich system, and in between is the current system. But that was not my final comment.
Okay.
I think UBI as with everything else, UBI gives the poor people enough money to finally makes the poor people rich enough that the producers will finally pay attention to them.
Mm-hmm.
That there's simply not, for instance, in America, there is no cheap house, mostly because of regulations.
Right.
Mm-hmm.
If you said, oh, I'm poor, I want to buy a house that has no electricity or no smoke alarms, is a fire trap, well, it's just illegal.
Right.
Maybe it shouldn't be illegal, although a few of those are pretty good. But basically, there isn't an economy of poor stuff, of cheap stuff for poor people.
Right.
But if the poor people can get a little bit richer, then they will actually be
they
a
have
profit.
$10,000 like 3D printed houses and things that they're coming out with.
That's cool. Yeah.
Okay, see, as usual.
If only the
Richard
poor
already
people had
knows.
$10,000. Yeah.
You know, Richard already knows how the market
How to
will.
solve it.
Why do I leave
I think you're right, though. I think that's
Yeah,
exactly
it's a
right.
good point.
Richard?
One way to drive down costs is with like the Da Vinci surgical device. They actually can have the best doctors. Like they recently had, I think it might have been last year, they had a doctor for the first time in like Europe perform a surgery in like New York because the latency was low enough that they could do that.
Wow.
What do you mean?
Like he remotely did the surgery with a robot.
remotely.
Like kind of like you were talking about someone across the world.
Oh, yeah.
Yeah. That's
And
amazing.
they also, in poorer countries, they have like telemedicine, where they can have a doctor in the U.S. look at them with a cell phone or something like that. And they also have like a tricorder thing that they're working on that they can like take a drop of blood and put it on this like a cell phone attachment, and they can provide an answer, and they can like send it in an email or something like that to a doctor, and they can look at it too.
That's really cool.
Yeah, that's cool.
All right. Well, I think my final thoughts are just going to be that healthcare can be a lot more efficient than it is now in a lot of ways, and we've identified many of the ways, many of the changes we could make that would achieve that. There are some aspects of the healthcare system that are amenable to market allocation, and for those things, basic income is going to be great, and it can help that part of the healthcare system be a lot more efficient, and also maybe give us an opportunity to figure out what makes sense in other parts of the healthcare system, or maybe make it more amenable to the market, or figure out where insurance is really the thing that makes sense and all of that.
Yeah. And Mitchell had a fun comment.
And Mitchell's thought is, this is a relevant topic to all, as health has a major impact on everyone's life. Oh, and I may have to defrost the cheesecake after reading that article.
Yeah, sounds good.
Yeah.
I know, I was staring at that.
All right, so thanks guys for the discussion. We went a little bit over.
Yeah.
So tomorrow night is the
Debate.
Yeah.
is the third Democratic presidential primary debate.
Yeah, everyone.
And then next week we're going to be talking about that, and it's going to be on Tuesday.
Okay.
Yeah.
Our next two discussions are both going to